This lecture presents the white blood cell disorders, platelet disorders, and coagulation system disorders. The white blood cell disorder originates from multipotent uncommitted stem cells in the bone marrow under the influence of regulatory factors such as cytokines, interleukins, and colony-stimulating factor. Precursors are produced as blood cells and lymphocytic precursors, which are later subjected to further transformation in lymphoid organs. The maturation in neutrophilic leukocytes is further regulation by a corresponding granulocyte colony stimulation factor. Monocyte maturation is regulated by a monocyte colony stimulation factor. Eosinophilic and basophilic maturations are regulated by colony stimulating factors and interleukins. Thus, a formed element disorder either increase or decrease into the counts or dysfunction of the blood cells may be due either to damage to the bone marrow or to lymph nodes, or to some defect related to the absence of some regulatory components, cytokines, and colony-stimulating factors. This slide illustrates the normal distribution of leukocytes in the body. In the bone marrow, in the tissues, marginated pool, this is the amount of leukocytes crossing boundaries between these compartments, and of course the circulating pool, the counts into the blood. The leukocyte counts in the blood may be either increased leukocytosis or decreased leukopenia. Let me note that leukocytosis is physiologically phenomenon, especially in newborns, during heavy physical work, during pregnancy, and after eating, postprandially. The increased count of leukocytes is most commonly due to infectious and inflammatory processes. This is here the picture illustrating the change in infection. The bone marrow amount is decreased due to the release into the bloodstream and into the tissues of neutrophilic, mainly neutrophilic leukocytes. As you can see, the marginated pool, the amount of leukocyte crossing boundaries is highly increased because of the release from the bone marrow, and tissue residing leukocytes are highly increased. The leukocytosis may be due to predominantly increase of neutrophilic leukocytes, polymorphonuclear leukocytes. This is known as neutrophilia. It is indicative for acute inflammations, especially for a purulent inflammation caused by streptococci, ostophilococci, or meningococci. Severe inflammatory disorders are characterized by the appearance into the blood of less mature forms, bands, neutrophilic bands. So this is typical for the severe infections and inflammatory responses. Eosinophilic leukocytosis, eosinophilia. This is the leukocytosis observed especially in allergic disorders, such as hay fever, asthma, some drug reactions. Also, parasitic invasions such as amebiosis, fungi infections, some severe skin disorders such as pemphigus, in sarcoidosis, and cancer, especially in Hodgkin's disease. Basophilic leukocytosis, basophilia, is extremely rare. It is indicated for some rare myeloproliferative disorders and other malignancies. Monocytosis is indicated for some collagen vascular diseases, autoimmune diseases such as systemic lupus erythematosus and rheumatoid arthritis, also for chronic infections, especially tuberculosis and brucellosis, and some chronic inflammation such as Crohn's disease and ulcerative colitis. Lymphocytosis is usually present in acute viral infections and also in some chronic infections such as tuberculosis and brucellosis. This slide illustrates the picture of leukocytosis, excessive amount of leukocytes into the blood. The opposite condition, decreased counts, leukopenia, is illustrated on the screen. As you can see, it is quite different as compared especially with the leukocytosis. Leukopenia may be due to decreased marrow activity, for example because of use some drugs, especially some toxic antibiotics and anti-cancer drugs may cause suppression of the marrow activity and thus to produce leukopenia. Radiation exposure. A cyclic neutropenia, I will illustrate it a little bit later, due to some genetic disorders. Also, megaloblastic anemia also causes decreased marrow activity and leukopenia. Aplastic anemias due to damage to bone marrow. Marrow tumors destroying the bone marrow. And finally, some rare myelodysplastic syndromes. All they will cause leukopenia because of decreased production. The survival of the leukocytes may be also affected. For example, in sepsis, leukopenia is due to decreased survival of white blood cells. Some severe infections, such as viral or rickettsial, even without causing sepsis, may also cause leukopenia. And finally, some immune destruction process may occur due to antibodies, for example, after blood transfusions. This slide illustrates the so-called cyclic neutropenia, a disorder characterized by cyclic decrease of neutrophilic counts. The etiology is not yet fully elucidated. Some genetic predisposition is present, especially there is a defect in an early progenitor cell clone, thus causing decreased responsiveness to the colony-stimulating factors. As a consequence, the storage pool of granulocytes in marrow is not adequate. There are striking variations in their numbers. The neutrophil production occurs in discrete waves. They are shown here, waves of production for two different patients. The full cycle is about 19 to 20 days and includes a true and a peak. During the true, the counts of neutrophilic leukocytes are not inadequate to realize the defense of the body. As a consequence, the condition complicates with severe bacterial infections, generally from enteric organisms, and also fungal infections. During the true, the cycle is characterized by inflammatory changes such as lymphadenopathy, oral ulcers, skin infections, gums into the mouth, and so on. Inflammatory complications are observed during the true in about 50% of these patients. The leukocytosis and leukopenia illustrates changes, especially in amount, quantitative change into the white blood cells. We have to discuss now some disorders characterized also by qualitative changes into the blood cells. Leukemias. Leukemias represent neoplastic disorders of hemopoietic tissue with primary myelogenesis, and they are progressing, causing very often death. They are characterized by hyperplasia, defective maturation and differentiation with accelerated mitosis and production of non-mature cells. Leukocytosis are also characterized by metaplasia, production of leukocyte cells outside of the bone marrow, extramedullary, for example, into the spleen, into the liver, and in severe cases even in myocardium and kidney. The peripheral blood demonstrates increased amounts of young, non-mature blast cells together with differentiated cells. This is here the typical picture of blast cell count increase. In accordance with the type of the cells, leukocytes are lymphocytic. Leukemia, this is a synonymous term of leukocytes, lymphocytic or myeloid. They originate from either lymphoid stem cells or myeloid stem cell precursors. Further, they are divided in accordance with the outcome into acute leukemias and chronic leukemias. This slide illustrates the pathogenesis of the acute leukemia. The excessive leukocyte precursor growth in the bone marrow may be due, for example, to a lymphotropic virus infection, the HTLV, human T leukemia lymphoma virus, or to other factors interacting with the genome and thus causing mutation, physical factors as radiation or chemical factors such as petroleum products, benzene, among others. Regardless of the cause, the excessive growth will cause proliferation and accumulation of blast cells into the bone, local bone invasion, and thus bone changes. Pain may be generated. Also, this will disrupt the normal marrow function, especially to suppress the production of cells normally produced into the bone marrow, leukocytes, erythrocytes, and thrombocytes. Thus, complications may be generated. Neutropenia, decrease in the counts of the neutrophilic leukocytes, may be related to complications such as infections. Anemia, decreased counts of the red blood cells, will be due to the disruption of the synthesis into the bone marrow of precursors. And finally, thrombocytopenia, as we will see later, is related to impaired hemostasis and bleeding. The bleeding will further contribute to the anemia, to potentiate the anemia. The changes described till now characterize the early phase. The late phase is characterized by metastasizing and clonal progression of the blast cells. As already noted, extramedullary hematopoiesis due to metaplasia may be observed, and splenomegaly, hepatomegaly, and other systemic effects. The start of the acute leukemia is abrupt. The sick people will report weakness, fatigability, loss of appetite, and loss of body mass. The disease will progress by an anemic syndrome, hemorrhagic syndrome, and decreased defense till the death of the patient if not adequately treated. The early diagnosis strongly contributes to the successful treatment. The adequate treatment, chemotherapy by cytostatics, corticosteroid use, and eventually transplantation of bone marrow may achieve a long-term remissions, especially in children. The treatment is successful in about 90% of the cases. In chronic leukosis, genetic changes also play a role. Mutations due to impact of some chemicals, insecticides, especially some industrial products, and also in combination with family predisposition, thus causing mutations due to deletions, thus damaging of a suppressor gene. This is the most common form of leukemia, causing chronic lymphoid leukosis. Less commonly, acute myeloid leukosis may be present, which is due mostly to the chronic exposure to ionizing radiation and some petroleum derivatives, benzol and others. In chronic myeloid leukemia, a characteristic change is present. The so-called Philadelphia chromosome is found, translocation from the 9th to the 22nd chromosome. The fusion gene created in this way represents an oncogene activating some enzyme and producing gene changes. The resulting gene is stimulating the proliferation. The chronic myeloid leukemia demonstrates with an exacerbation phase with febrile fever, pains in bones, increased weakness, loss of body mass, and lymphadenopathy. Blast cells are increased in the blood. The other phase, the next phase, this is the phase of blast transformation, blast crisis, in which the blast cells may exceed 30% into the blood, thus creating complications, vessel occlusion, hyperuricemia, and damage to the central nervous system. Treatment of chronic leukemias includes more commonly cytostatics, but also alpha interferon, some enzyme blockers, and finally transplantation of bone marrow. Let's now discuss the lymphomas. Lymphomas are malignant disorders originating from the lymph tissues. They start from a group of lymph nodes with generalizing later, including all lymph nodes, the spleen, and some organs. Two types of lymphomas exist: Hodgkin lymphomas and non-Hodgkin lymphomas. The slide illustrates a preparation from a patient with Hodgkin lymphoma or Hodgkin disease. The etiology of the disease is not yet fully elucidated. The participation of the Epstein-Barr virus is very probable. It is supposed that Epstein-Barr virus activates the transcriptor factor, nuclear factor kappa B, thus providing stimulation for additional mutations, resulting in the appearance of the giant Reed-Sternberg cells. These are the typical neoplastic cells resembling the O because of the presence of two big nuclei. The Reed-Sternberg cells are highly active. They express CD4 receptors, which are known to generate a signal amplifying the effect of the nuclear factor kappa B, thus potentiating the neoplasia. As we can see, they are also releasing a lot of cytokines, as shown here. Cytokines are participating in the pathogenesis, especially the tumor necrosis factor, of the fever commonly observed in patients with Hodgkin disease. The disease starts with lymphadenopathy, increases of the peripheral lymph node, typically starting into the cervical area, with fever, loss of body mass, sometimes itching, persisting itching, and pain into the lymph nodes after taking alcohol. This is not yet explained how. The disorder progresses, invading more and more lymphatic channel, especially crossing the diaphragm and penetrating the intra-abdominal lymph tissue. The treatment usually includes chemotherapy combined with radiotherapy. The other group are the non-Hodgkin lymphomas. They represent low-grade malignancy lymphomas, well differentiated, normally due to some chromosomal translocation, an example the follicular lymphoma. They usually present with well differentiated cells. The other subtype, the high-grade malignancy non-Hodgkin lymphomas, express immature antigens, and they fail to express differentiation markers, especially immunoglobulins or T-cell receptors. The clinical characteristics present with invasion, infiltration, destructive, aggressive growth, lesions of adjacent tissue, accompanied by pain and bleeding, and also fever and weight loss due to release of cytokines, interleukin-1 and tumor necrosis factor alpha. Very often, hemolytic anemia is present. The treatment is very difficult. Let's now consider the platelet disorders. This slide illustrates the production and the maturation of the platelets, starting from the bone marrow nodepotted uncommitted stem cells, the committed stem cells, the blast cells, megakaryocyte, and platelets. It is regulated by a lot of cytokines, interleukins, colony-stimulating factors, especially for megakaryocyte production, interleukin-6, granulocyte, monocyte, colony-stimulating factor, and the thrombopoietin. The disorders are quantitative and qualitative. The quantitative disorders include increased counts, thrombocytosis, or decreased counts, thrombocytopenia. This slide presents smears from normal blood. As you can see, these are the thrombocytes here, and the thrombocytopenia, a very scarce thrombocytes present. Platelets participate mainly, but not only, in the coagulation process. Here you can see a quiet resting platelet and an activated platelet, micrographs. And on the scheme, the main components, especially, let me stress on the presence of proteins such as glycoproteins 2b and 3a complex, the glycoprotein 1b, collagen, thrombin, and ADP receptors, and the selectin presence. The activation, in addition to the changes, conformational change into the membrane, results in activation of the complex glycoprotein 2b, 3a, activation of some coagulation factors such as coagulation factor 5, converting the prothrombin to thrombin, expression of active receptors binding to the von Willebrand factor, the glycoprotein 1b, and release of adenosine diphosphate, serotonin, and also platelet factor 4. This is an important coagulation factor. This picture shows the binding of the receptors to the corresponding ligands, to the collagen, to the von Willebrand factor, and especially to fibrinogen. The complex 2b3a ensures the binding to the fibrinogen and thus the aggregation and the activation of the platelets. The activated platelets release arachidonic acid products such as thromboxane A2, adenosine diphosphate, and other products. Thus, the sequence of events includes adhesion to the wall, aggregation, and activation to release coagulation factors and prostaglandins, together with ADP and other factors. Thrombocytosis is observed rarely. In some essential disorders such as myeloproliferative disorders, sometimes in inflammatory disorders and in malignancies. Most commonly, thrombocytopenias are observed. Thrombocytopenias may be due to decreased production, for example in aplastic anemia, damage to the bone marrow by radiation, or vitamin B12 or folate deficiencies, or to a decreased survival of the thrombocytes, or it may be caused by drugs. I will give you a little bit later an example, the so-called immune-mediated, drug-mediated thrombocytopenia. Dick syndrome, the disseminated intravascular coagulation, also causes thrombocytopenia, as will be also demonstrated later. And some qualitative disorders may be also present, inherited mutations in some important receptors or proteins, as will be shown later. Now, let's comment the drug-induced immune thrombocytopenia. A lot of drugs are described to do that, but I will focus on the role of heparin. Heparin is largely used as anticoagulant after surgical interventions, but other medicine, especially non-steroid anti-inflammatory drugs, sulfonamides, cimetidine, ranitidine, and others may also play the same role. Now, the pathogenesis of the heparin-associated immune thrombocytopenia. Platelets are known to release the platelet factor 4. This is important coagulation factor. So, if blocked, this will produce anticoagulant effect. That's why we are using heparin. The heparin will bind to the platelet factor 4, thus to neutralize its effect on coagulation. Usually, this complex is non-antigenic, except 1 to 5% of the population in which the complex is somehow becoming immunogenic. So antibody is produced against the complex, and the antibody will bind to the complex. As a consequence, aggregation of the thrombocytes will be produced with subsequent destruction, or in other words, loss of thrombocyte due to the immune process, to the platelet aggregation. The resulting thrombocytopenia will cause complications such as bleeding. And another complication results from the presence of heparins into the vessel's walls, heparin or heparin-like. So, the platelet factor 4 will also bind to these heparin-like molecules, and as a consequence, an immune complex will be produced at the surface of the endothelium. We all know that deposition of immune complexes on endothelial cells will cause damage because of activating the complement system and causing inflammatory response and damage to the endothelium. And the endothelial cell damage, as already discussed earlier, is a main cause into the vessel to produce thrombosis. Thus, paradoxically, heparin use to prevent thrombosis, a complication, may produce thrombosis in sensitive people. This is the picture of the thrombocytopenia due to the immune response against the complex heparin platelet factor 4. Another form of immune disorder causing destruction of thrombocytes, this is the autoimmune thrombocytopenic purpura. It is known as essential thrombocytopenia or disease of Velhoff. Autoantibodies are present in the patients due to cross-reaction, especially after viral infection in children, or autoantibodies against membrane glycoproteins of the thrombocyte in adult women. In both cases, the clinical demonstration include hemorrhage, petechia, epistaxis, and hematuria. Let's now comment some qualitative changes in the platelet function. First, the disordered thrombocyte adhesion in von Willebrand disease. This is shown here. Defective binding to the von Willebrand factor because of low concentration or modification of the von Willebrand factor. As a consequence, the adhesion of the thrombocyte will be defective. Adhesion is disordered also in another inherited syndrome. This is the Bernard-Soulier syndrome with defective ligand, glycoprotein 1b, or in another deficiency, the aggregation is defective because of the defective ligand, the complex glycoprotein 2b, 3a binding to the fibrinogen. We'll now discuss the coagulopathies, the defects in the coagulation process. This is here the coagulation cascade shown. It is well known, I will not comment, but I will focus especially on the deficiency of some factors. The factor 8, it is known also as antihemophilic globulin. Its deficiency is genetically caused, and it causes a disease known as hemophilia. The disease is usually inherited, but new mutations are also present. The mutation of the gene for the antihemophilic globulin, factor 8, is localized on the X chromosome. That's why patients are male persons. This slide illustrates how the defective chromosome is transmitted. Here, a couple with the hemophilic male and a normal female may produce all these variations of children. Normal male children and carrier female children. So, let's now consider which is the role of the carrier female children. In a couple with a normal male, the carrier female will produce either normal male or normal female, but also hemophilic male and another carrier female. In other words, the sons are healthy while the daughters are carriers. The hemophilic sons are healthy while the daughters are carriers. And later, the carrier daughter, even with normal male partner, will produce a hemophilic male. Thus, boys are the patients. The manifestation of the disorder will depend on the stage of the damage to the gene. For example, the factor 8 may be decreased at different level. A decrease with 15% causes a massive bleeding after a surgical intervention, but not spontaneously. Further bleeding will be produced spontaneously in a huge decrease, 1% of the normal level present. Bleeding are observed in these boys, hematomes, hemorrhages, hemarthrosis, blood into the joints, and they are also accompanied by complications, inflammatory responses, ankylosis, and compressions. In the dental practice, a huge hemorrhage may be caused by the extraction of teeth. The treatment in these patients is replacement treatment, infusion of a recombinant factor VIII obtained from healthy persons. Let me note that coagulation disorders may be secondary, induced by other factors, for example, another pathological process or the use of some therapeutic medicine. Especially the deficiency of vitamin K deficiency may be due to deficiency of the intake or the suppression by the normal flora after long-term antibiotic therapy, or disordered storage in hepatocyte, in hepatitis, or use of antagonists. The deficiency of the vitamin K effect causes coagulation disorders, extended prothrombin time and partial thromboplastin time. This is accompanied by hemorrhages. In some patients, bleedings are not due to coagulation disorder. Instead, they are due to changes into the vessels. For example, changed structure, defective structure, or defective permeability. So we have to differentiate into the practice between the vessels damage and coagulation process disorder per se. This slide illustrates the mechanism of the bleeding due to vessels defect. For example, two main factors: vessel damage or defective vessel support. Vessel damage may be due to infection. It is observed in a disorder known as anaphylactoid purpura of Schönlein-Henoch, usually after a streptococcal infection, because of the vasculitis, deposition of immune complexes, damage to the vessel, with increased permeability, exudation, and hemorrhages. Vessel damage, increased vessel fragility, and bleeding. This is observed in the purpura of Schönlein-Henoch. Other factors: drug reactions, immune reactions, autoimmune disorders such as systemic lupus erythematosus, causing immune complex deposition, also may damage the vessels and to cause bleeding. Snake venoms also directly damage the vessels and cause bleeding. Defective vessel support. It may be due, for example, to a disorder known as hemorrhagic telangiectasia. This is the disorder, the disease of Randu-Osler, due to a genetic defect. Telangiectasia, extensions of the vessels because of the defective vessel support and increased vessels fragility is observed with rupture of vessels, bleeding, and loss of blood. Other factors contributing to the bleeding due to vessels fragility are the excessive corticosteroids or vitamin deficiency, causing weakening of the collagen and loss or defective of the vessel support, and aging also decreases the vessel support, thus causing a risk for increased vessel fragility and bleeding. We consider till now cases and mechanisms of hypocoagulations and bleedings. Let's now consider an opposite condition, excessive hypercoagulation. It is usually due to disordered balance between coagulation factors and anticoagulation factors. This scheme illustrates the coagulation cascade and especially the anticoagulation factors normally present into the organism. The normal coagulation results from a balance between coagulation factors and anticoagulation factors. Now, let's consider a few cases. For example, protein C resistance is described. The decrease of the effect of the protein C will cause excessive coagulation and will generate a risk for thrombosis into the blood vessels. The protein S, a case of protein S deficiency, is described causing the same effect, deficient anticoagulation effect and hypercoagulation with thrombosis. And the last one, antithrombin 3. Antithrombin 3 deficiency is also described as a primary genetically mediated disorder. In all these cases, thrombosis, especially in deep veins of the legs, are observed, causing severe complications. The most severe complication of deep vein thrombosis is the release of a thromboembolus that may cause obstruction of the pulmonary artery, pulmonary embolism. Now I will focus on an important syndrome, the disseminated intravascular coagulation syndrome. This is not a disease. This is rather a secondary complication of a variety of diseases, either acute or chronic. The disseminated intravascular coagulation syndrome is observed mainly in obstetric patients. They represent 50% of the contingent during pregnancy complications. Another 30 to 35% are observed in carcinomatosis, different tumors, and the remaining patients are usually suffering from sepsis or a major trauma. The pathogenesis of the Dick syndrome includes two main factors: release of tissue factor thromboplastin and endothelial injury. The first one, release of thromboplastin, is observed in obstetric patients. For example, placenta is a source of tissue factor. Also, the granules of the leukemic cells also release thromboplastin. Mucus produced by some tumors, adenocarcinomas, also contains thromboplastin. Endothelial injury is due to the release of tissue factor from the cells and also by the activation of intrinsic coagulation pathway, exposure of subendothelial connective tissue. These are the factors involved into the pathogenesis of the Dick syndrome. In a lot of cases, the endothelial injury may be due to deposition of antigen-antibody complexes. The activation of the coagulation process will release an uncontrolled thrombin generation with fibrin deposits into the microcirculation. This will cause secondary fibrinolysis and the release of dimers. This is an important mark of the Dick syndrome. It is checked in the clinical laboratory. But fibrin deposition in the microcirculation will cause obstruction of small vessels into the microcirculation, and thus they will cause local ischemia with tissue damage up to necrosis and causing multiple organ failure. Even microinfarctions may be observed, especially in kidneys, lungs, brain, and adrenals. The other demonstration, because of the uncontrolled thrombin generation and overconsumption of platelets and coagulation factors, they are consumed very quickly. They are not replaced so quickly, so deficiency of coagulation factors is generated and diffuse bleeding is present simultaneously with the ischemic tissue and thrombosis and the obstruction of the vessels. A paradoxical condition. Thrombosis and bleeding are present into the same patient in the same time. Clinical manifestations of the Dick syndrome include hemolytic anemia, respiratory symptoms with dyspnea and cyanosis, neurologic signs because of the affection of the brain, including convulsions and even coma, damage to the kidney with acute renal failure, demonstrating with oliguria, and finally circulatory shock because of the increased permeability and loss of fluid. As you can see, a severe complication may be present, or complications, multiple organ failure, into Dick syndrome. The treatment should be directed against the cause, the disease generating the disseminated intravascular coagulation, but also to block the hypercoagulation, to block the consumption of platelets and coagulation factors. In the late stage, characterized by diffuse bleeding, transfusion of plasma and thrombocytes is applied to stop the diffuse bleeding.